Okay, hello and welcome to today's webinar, Fostering Life Skills in Young People to Prevent Suicide, Challenges and Opportunities. My name is Renato Oliveira. I'm the Chief of the Mental Health and Substance Use Unit at the Pan American Health Organization. It's my great pleasure to welcome everyone joining us via Zoom or YouTube. And a special thank you to the University of Toronto for co-hosting this webinar, especially to Dr. Mark Senior and Danielle Sanchez Morales, and to our three wonderful presenters. I would like to remind you that simultaneous interpretation is available in English and Spanish. To activate translation, click on the globe icon on the bottom of your screen and choose your preferred language. Les recuerdo que la interpretación simultánea está disponible en
This
inglés.
is a reminder that we have simultaneous interpretation in English and Spanish. To activate translation, click on the globe icon on the bottom of your screen and choose your preferred language.
Colleagues, this is the third in a series of webinars jointly organized by PAHO and the University of Toronto, aimed at discussing suicide in the Americas and how it can be prevented. We have interventions based on the best evidence available, which when properly implemented have been shown to reduce suicide rates. In particular, the World Health Organization's Live Life Implementation Guide for Suicide Prevention in Countries outlines 4 key effective interventions, which have served as the topics of our series of webinars. Our first webinar, held on September 10th, World Suicide Prevention Day, focused on changing the narrative and responsible media reporting. The second, on November 14th, addressed early detection and intervention, highlighting the promising experiences of crisis helplines. Today, we will address the crucial issue of fostering social-emotional learning and life skills in young people, a core strategy for preventing suicide. Following all of the presentations, we will have time for questions and answers. We encourage you to use the question and answer box to share your questions at any time during the webinar. And now, it's my pleasure to introduce our first presenter, Dr. Andrea Spiridu, who currently serves as the Regional Mental Health and Psychosocial Support Advisor for UNICEF's Latin America and Caribbean Regional Office. Her expertise spans perinatal mental health with a focus on PTSD during pregnancy and postpartum and child-adolescent mental health and well-being. She has worked in crisis settings across Greece, Syria, Iraq, Lebanon, the Democratic Republic of Congo, Bahamas, and also in many developing settings in Latin America. Andrea, it's really a pleasure to have you with us, and the floor is yours.
Thank you so much, Renato, and thank you for this opportunity. I'm very happy to be with you today among all the other panelists and to share this experience from the Helping Adolescents Thrive approach initiative in the Latin America and Caribbean region, and bringing 2 examples from Ecuador and Venezuela today. So we know that mental health outcomes in children and adolescents in LAC are not really promising. We have seen that things are getting worse, especially during and after the pandemic. And currently we know that 15% of children and adolescents aged 10 to 19 in our region, that means about 16 million, live with a diagnosed mental disorder. And unfortunately, suicide continues to be the 3rd cause of death among this age range, which translates to more than 10 adolescents in the region losing their lives to suicide. And in some countries, we know that among girls or among boys, this cause can be the 2nd cause, and in some very extreme cases, even the 1st cause. So that is why we are really trying to focus on through UNICEF's work on prevention and promotion strategies that could actually mitigate these all the risk factors that are there for this age group. With these high prevalence rates, we know that risk factors like exposure to violence, economic instability, and displacement all have a key role in increasing the risk for mental health for adolescents. And combined with the limited access to mental health services, this becomes even more dire. We know also in terms of development that adolescence is a critical period for intervention, as we call it, many times a second window of opportunity to intervene and change the course of things for adolescents' lives. So the HAD is a joint effort of UNICEF and WHO. It focuses on mental health, adolescent mental health and well-being through the promotion of mental health as a way to prevent disorders and reduce risk behaviors. It uses key strategies like policy advocacy, creating safe environments, and supporting caregivers of adolescents while building skills for adolescents to be able to better manage and support themselves and peers. And this is done through the implementation, of course, and enforcement of mental health policies, but also the creation of these safe and supportive environments through training of caregivers, but also equipping the adolescents with those very needed social emotional skills. And of course, we're trying always to reach children and adolescents where they're found the most, and that is into the education and also many times the protection services. And I'm going to jump quickly into the first example, Ecuador. Ecuador's context is shaped by high levels of food security and the presence of armed groups or criminal gangs. And there is also significant presence of population in the context of human mobility, especially in the Colombia-Ecuadorian border areas, with the presence of, as I said, dissidents, armed groups. Again, the leading cause of death in adolescent girls aged between 15 to 17 in Ecuador is suicide. And the homicide rate among children has seen an increase by 680% in the last 2 years. So this is really a very sharp increase of homicide rates. Now, everything that is being produced at the global level, we know that when it reaches the regions and the different regions and the country levels requires very thorough adaptations. And this is done to address the specific risk factors at the individual, family, or community level in the country. So that is what Ecuador UNICEF has done. It adapted the HAD guidelines jointly with the Ministry of Education, followed by a first capacity building that was conducted in 2022. It also helped to contextualize cases in attending mental health with an active participation of adolescents. And the adaptation also included changing the illustrations and characters of one of the guides, the Magnificent May guide, to the Ecuadorian context. In the implementation phase 1, 1,210 adolescents were reached and 803 caregivers and 2018 teachers. And this, the focus of Ecuador was to put mental health at the center of violence prevention, integration of psychosocial support, and communication strategies in order to build peer support networks and also strengthen the social emotional skills in order to safeguard the psychological well-being of children and adolescents. It engaged, the project focused on engaging in social cultural activities to express their emotions freely, and also other innovative methodologies such as the emotional escape room and cultural and sporting events. And through this, there were these different activities, 1,379 children and adolescents were reached. And what we've seen as results is that adolescents could be participating in learning spaces, of course, on prevention and promotion of mental health, but also they learned to identify emotions and tools on how to manage their emotions. And they developed new social emotional skills. And this is only some pictures from the different regions where the project was implemented. For the caregivers, we have seen improvements in effective communication with their adolescents. They were able to identify and manage emotions and develop positive discipline behaviors and conflict resolution skills. And for the teachers, they also received training, and they were able to accompany the process in parallel with their students. They developed soft skills in leadership, effective communication, creativity, resourcefulness, teamwork, and conflict resolution. And this is some more quantitative data that show actually the progress made after the training was conducted, where 90% of the adolescents and young people registered in the program attended all the workshops, 14 workshops that were held in Esmeraldas, Manta, and Tulcan. And these were adolescents between 13 and 19 years old. For the adults, caregivers, mostly in the baseline, we saw that 48% of them considered that they have already developed soft skills, while at the post-training assessment, this percentage rises to 93%. And on the variable of knowledge about mental health, the baseline was 38%, and in the post-training, it was at 95%. This is just a few examples of the increasing knowledge and skills that we were able to assess. And in teachers, we see similar increases in the baseline. 79 of them considered that they have developed soft skills, while at the post-training, it rises to 93%. In the phase 2 of the project, using a cascade model, by training more people and then becoming trainers and training more teachers, we see that the Ministry of Education has committed in including the HAT in the National Training Platform for Continuing Education of Teachers. And in the first cohort, we have 1,500 teachers finishing the training and facilitating mental health promotion activities, reaching 37,500 students in different schools across the country. So just as a conclusion, we ask ourselves, why do we need to use schools as a platform? We know that schools offer the perfect context where children and adolescents may feel safe, may be able to develop skills free of other worries or risk factors that are going on in their homes or their communities. So for us, implementing this program through these educational institutions facilitates the convening and the participation, and also the monitoring of both adolescents, caregivers, and of course, their teachers. And in this way, it allows the interventions to have a greater impact because of the immediate protective environment of the participation of all these groups. Good. So now we'll jump into a different context. We're moving to Venezuela. As you know, Venezuela has been shaped by severe economic and social crises, resulting in increased violence in the past years, poverty and deterioration of the essential health and education services are widespread. And these challenges are coupled with displacement and also prevalence of severe diseases that are exacerbated mental health and psychosocial needs among children, adolescents, and their caregivers. And in particular, adolescents are experiencing these heightened levels of anxieties and depression and stress due to the instability and lack of support systems. Many of them are left behind while their families and their caregivers had to emigrate. So similarly, there was an adaptation process in Venezuela, again, with the Ministry of Education technical directorates that had participated in the first training that was conducted. And technical working groups were developed in order to be able to reach these adapted versions developed for the Venezuelan context. And the first cohort of 48 professionals in the first phase from 8 regions is currently being expanded to many more through TOTs. And the expected impact is that national policies will actually be strengthened, improving adolescent mental health and well-being, and that finally these HAD guides will be integrated not only in education but also in health and protection sectors. And this has been already in course with collaborations with the Ministry of Health and the Institute of Protection of Child. So we've seen a lot of progress happening in Venezuela in the past few years with really amazing commitments from all these technical groups from ministries. There were proposals generated for the recovery of mental health care spaces for children and adolescents within the different sectors. There was an agreement to position the issue of mental health in communication spaces through social networks, and an action plan developed for the cascade replication of the HAD workshop in health education and protection across 8 states in the country. So in these states, we have seen amazing results, and right now we see that this implementation strategy following this cascade model will serve over almost 400,000 students of 4th and 5th grade in secondary education in around 6,000 high schools. And this will also mean involvement of specialized mental health services, creating referral networks between psychologists, psychiatrists, and other personnel who works with adolescents. Well, reaching the lessons learned and also future directions, we have seen from these 2 case examples, and I need to mention here that it was not only in Venezuela and Ecuador. We have another 6 countries that are currently implementing HAT, and they have followed similar approaches. And we're reaching to these conclusions not from all the countries that the HAT has been implemented. We see that there is a great need for sustained investment in adolescent mental health and also cross-sectoral collaboration. We also need to continue advocating because we know that this issue, the topic of mental health, especially in adolescents, is not a priority within the health budgets. And to reach even more children and adolescents, we need to scale up efforts also in other countries while strengthening the M&E frameworks for impact assessment. And a call to action for those of you listening, and I'm sure you have the platforms and voice to bring this message. We need to strengthen policy frameworks for adolescent mental health, expand the HAD programs, invest in training caregivers, educators, and health professionals, foster youth engagement in mental health initiatives, and in UNICEF LAC, we have many examples on how this can be done effectively, and ensure sustainability through local ownership and partnerships. And with that, I hope I didn't go beyond my time. I want to thank you for your attention, and here leaving you a few of the guides. And please do contact me if you want to get the English version of the guides as well. Thank you. Over to you, Renato.
Thank you very much, Andrea. No, you are perfectly on time. Thank you for that. But also, thanks for sharing with us a very good description of the comprehensive activities that UNICEF implements in the countries in this region. The activities that you shared with us are really crucial for adolescent and young people development and prevention of suicide. Thanks also, Andrea, for emphasizing in your presentations measuring outcomes. We know how hard it can be to measure outcomes out of the research settings in real life. And you have brought us very illustrative examples on how that is possible and the impact that those activities can have in young people. I have seen also that you gave us a lesson on how it's important to work in mental health from a multi-sectoral perspective. You brought clear examples of working with the educational sector, working in schools, and I think this motivates us to reach also other sectors because everyone has a role to play in advancing mental health in our region. You have shared also the links to the material in the chat. We have also put the link to the HAT material for the colleagues who are with us and are interested. Let me also mention that we have a limit of people who can attend this Zoom room, but we have also put in the chat the how people can connect to YouTube, where the transmission is also being done simultaneously. So if colleagues of the audience here are asking that they are having challenges to enter, you can direct them to YouTube through that link. And thank you again, Andrea. And I think it's also important that we mention that PAHO and UNICEF have been working together in the countries in this region. We are always looking into synergies on how to complement the work of each other. I think we have also very positive experiences in Colombia, in Guyana, where we work with the government in implementing HAT. So thank you again so much for sharing those experiences with us.
Thank you, Renato.
Thanks to you. Thank you. Let's then continue. Let's go to our next presentation. The next presentation is by Dr. Rachel Mitchell. Dr. Mitchell is a child adolescent psychiatrist at Sunnybrook Health Sciences Center and an associate scientist at the Sunnybrook Research Institute. She's also an assistant professor in the Department of Psychiatry at the University of Toronto. Rachel's research focuses on sex and gender differences in suicide and mood disorders in adolescents. She has received a Young Investigator Award from the American Foundation of Suicide Prevention and the International Society of Bipolar Disorders. Thank you, Rachel, so much for being here with us, and the floor is yours. Thank you. Rachel, we see the small slides also on the left. Perhaps you can click on full screen in the lower part of the... Yeah, and now display. Yes, perfect. Thank you. Great. We see it perfectly. And you're muted.
Sorry, the problem was I couldn't see my mute button because of everything that was on the screen. Hello, everyone. Hello, especially to all my colleagues who I have not yet met in the Americas. It's really a privilege and an honor to be here today. So thank you for this opportunity. And thank you for tolerating my transition, my less than smooth transition. That's a tour de force to follow from Dr. Andrea. I'm going to be talking to you about a topic that affects all of us because it's now ubiquitous to everyday life, and that is social media, and specifically self-harm and suicide-related content on social media, and what to do about it, the debate about it, and how we can approach the debate. As a disclosure, so I just want to make sure that you can see my next slide. Can you see my next slide? Yes?
Okay. Yes, we can.
Great. Thank you. As a disclosure, I consulted to TikTok, and the fees were donated directly to IASP for my time. So the objective of today is really to give you a lay of the land and to examine the trends in self-harm and suicide among adolescents so that we have a scope of what we're dealing with, at least here in the North, and review the literature, although limited, on self-harm and related content on social media. I'll show you very preliminary findings from a study that we have done on on the thematic analysis of self-harm and suicide content on TikTok. And then we'll discuss the debate on regulation versus empowerment with my suggestions as where we can go from here. And I think that the presentation that preceded this one, that kind of really multi-pronged, big thinking approach is probably where we're going to need to go here. But I'm going to start with a description of a case, but also a reference to Greek mythology, because I think the case or the story of Demeter and Persephone is a good, embodies a lot of the issues that we're facing when it comes to young people, social media, and self-harm and suicide. And interestingly, the result or the resolution of the story, I think we can learn a lot from. So the story goes where it's a young mother and daughter story. So they have a very close bond, especially as the daughter Persephone comes of age. And let's just call this first presentation self-harm, and she's really, really, really guarded with you. And the mother has discovered, the mother is Dimitri, and she's discovered that her daughter has been focused on social media and the self-harm content on TikTok, and specifically the For You page. And she's very distraught. And so that's the modern day story that we're dealing with right now. But the Greek mythology story is that Persephone and Demeter are very close. And Persephone is one day walking, and she gets, and the god of the underworld falls in love with her, which is a good metaphor for social media, and sort of captures her to the underworld. And it's about how Demeter manages it. And then, of course, in the process, Persephone falls in love with the god of the underworld and doesn't want to go back to the world above, which is sort of, again, metaphorical to the situation we're managing here. And the other thing to say is that Demeter is the god of agriculture, goddess of agriculture. So she teaches the mortals about how to cultivate the earth and grow food. And without her, they can't survive. And so she's very angry, and so they're suffering from the consequences of that. I'll try and revisit this, but it won't really come back until the end. Okay, so we're going to examine the trends in suicide, and I'm going to focus on Canadian youth. So what you can see here is a trend in suicide, not dissimilar to ones we're seeing in the Americas, but essentially the top line is blue for male, and that's the older male group, and the bottom lines are the red is for female. And what you can see is that the top lines are staying the same or decreasing, whereas the rates in females and younger females in both age groups are increasing. And that's seen in these graphs from 1982 all the way to 2018. You can also see that in the graph on 2006, that the gray line and the red line right at the bottom in the 10 to 14 years, all the way to 2006, they sort of meet, which is very unusual because males die by suicide more than females. This is a known sex difference all across the lifespan in most places in the world, not in most places of the world, in most places of the industrialized world. Actually, I have to be very careful about that. At least in North America, and the industrialized in this kind of, in the G8, G9 countries. And so it's really unusual to see that, that trend. And unfortunately, that trend continues from 2009 all the way to 2018, at least in Canada. Females in that age range specifically continue to die by suicide more than males in that age group. And that rate increased by 7% per year. So really, it's showing the vulnerability of this age group. And the story for self-harm, again, at least in Canada, is the same. So this is data from Ontario. It's administrative data, and it's showing emergency presentations for self-harm pre and post-pandemic. And what the solid line shows is what is what was observed, and what the broken line shows is what was expected. So we predicted, if past predicts future, what the self-harm should be, if the trends continue. And then the solid line is what we actually saw. And you can see that there's a big disconnect between the observed and the expected. And although I'm not showing it here, that trend is largely driven by females and younger females. And so what I'm getting across in summary today is that when we're talking about social media and self-harm and the suicide and self-harm related content on social media, essentially the trends in suicide and self-harm among adolescents are creating conditions in heat that are ripe for fire. So fire needs three things. It needs oxygen, it needs heat, and it needs fuel. And so if you want to consider, for example, another metaphor, oxygen being the factor that's rather constant, and the heat will go up and down, maybe depending on the season. And so the trends in suicide and self-harm among adolescents are really creating conditions ripe for fire. So that's the heat. We're at the top of the summer heat. Or at least in Canada, in our national parks, we get warnings not to camp and not to make fires because of how hot it gets, and because of the risk and danger associated with the fire. So next, to review the literature on self-harm and suicide-related content on social media. And the truth is that it's a very not clean message, let's just say. It's a very not simple message. And that's partially because it's such a complex topic and we're asking very simple questions and expecting to get simple answers. And so I think that the literature is very muddled. And that's because, as we know, social media can be good for some, and it can also be bad. And that's putting it very simplistically. And it can also depend on the very moment. And so what social media is good for one person one day in a certain circumstance is entirely not the same the next day in the very same circumstance. And so a lot of the literature really doesn't inform what to do in these scenarios. And so that's where, at least in the US, the Surgeon General, now former Surgeon General, had some foresight to, despite the lack of evidence, because there really isn't a lot of clear evidence in the way that us researchers like to see in terms of a signal. But you just have to, he used, common sense and said that there's harmful content, exposure is excessive and potentially problematic, and these are primary areas of concern. And then it's also the extremeness of the content and the appropriateness of the content and how harmful that potential is for that and how accessible it is. And those words I emphasize because I think it's a big part of the problem. It's excessive, problematic, and widely accessible. And the fact that there is harmful content, and that is occurring in the context of this suicide crisis that we're seeing. And specifically, the issue when we talk about the dangers related to social media and self-harm and suicide-related content on social media, the danger is, of course, contagion. And so the idea is that you have very poor distress, mental health for some reason. Of course, it's circular. What came first, the chicken or the egg? That's why it's so difficult. Then there's the algorithm that knows that you're distressed. And then you have the exposure to the self-harm and suicide-related content. And that creates conditions that are ripe for contagion, which is suicide and self-harm. And really, wherever you go on the continuum there, whether it starts at the top or the corners, it's a problematic because what it's described is a sort of a rabbit hole or a loophole. Even if you didn't want to see the content, the algorithm at times can feed you that content. And there's studies emphasizing that. But nevertheless, the research on the topic of what is the impact or outcome of viewing self-harm and suicide-related content is really not clear. A research review showed that 15 studies was harmful, 9 studies were protective. One group of researchers concluded that clinicians need not be overly anxious for whatever reason. And then really there's a wide ranging of reactions with empathy and solidarity to worsening of behavior. Some people feel very validated and understood when they see other people feeling how they're doing, how they are feeling, and engaging in self-harm behavior. Of course, it's a sense of belonging, it's connection, and that can be very protective. So that's why the literature. So it's not very clear that just de facto you're exposed to self-harm and suicide related content that's gonna, therefore result in suicide or self-harm contagion. But the idea is that it could happen. But to first find out what the impact of this material is, we have to at least know what's there. And I'm only going to present, in the interest of time, very brief findings. What we did was a thematic analysis of self-harm and suicide-related content on TikTok. And we examined the hashtags, we characterized the content, and then we came up with themes based on that content. And I'm not going to take you through the methods, but I just want to show you these because I'm sure they're obsolete by now. But what we did was we did hashtag sampling. So we took the most popular hashtags and view the videos accordingly. That's how we did our sampling. But just to show you some of the how easy it is to circumvent the algorithm, because of course you can't type in self-harm or suicide into the algorithm of TikTok, but there's lots of different ways or euphemisms that you can use to circumvent it. And I'm sure these are all, like I said, obsolete because by the time they figure out what they are, they've come up with new ones. And it's as simple as suicidal with 2 eyes, or unalive myself, unlive me. There's lots of different ways. But in any event, I'll just show you. So the top 10 hashtags were based on popularity, and these were the hashtags that defined the videos that we saw. And the top one was SH for self-harm, just like that. It's totally possible to search that in TikTok, in the app. And that was seen in June 2023, 7.4 billion times. And the reason why I can't update that is because that function is not available. And so really, I decided not to spend a lot of time talking about the themes that we discovered for the purposes of this presentation in the interest of time, because I really wanted to spend time on the debate. But I'll just tell you that there were 5 themes. Some of them were very emotionally laden, potentially negative, with a lot of negative overtones. But in the very same study, there was really hopeful, strong, poignant messages that would connect with kids who were struggling. And then there were also messages, even using humor, that if you were potentially having a bad day or looking at that might even make you laugh and then change how you feel in that moment. So just to show you the complexity of the content that's on there. But safe to say, the self-harm and suicide-related content on social media really provides fuel for the fire. So that's the corner there. So we have the heat, which is the suicide trends, but then you have that content, which is the fuel, and the oxygen, which is the content. But the determining factor really is the wind, or like the kind of fuel or how much fuel. And the problem is that which way is it going to go? Is the wind going to go this way or this way? And you won't know. And it's really hard to come up with a problem at such a grand scale when it's so variable and dynamic. And so I wanted to spend some time talking about the debate because I think we have not yet figured out exactly how we're going to do this. Yet I think that the story of Demeter and Persephone, which I'll go back to, can teach us. But let's first discuss the things involved with regulation versus the other way of dealing with it, which is empowerment. So you've got regulation, which is top down, and then you've got empowerment, which is bottom up. And it's a different approach. On the one hand, what got me interested in this, on one hand, in the context of the heat knowing that the fuel is there, wouldn't you want to just regulate the fuel? That's where I started in this approaching this field. Like, how could we not regulate the fuel if you know that you're going to add fuel to the fire and that's going to result in suicide? But it's not that simple. And that's what I've come to appreciate. And the answer isn't necessarily regulation and making sure there's no fuel whatsoever, because that fuel is always going to be there. But the debate really has to do with left and right and which part of the political spectrum you're on. It has to do with violations of autonomy versus not. It has to do with freedom of speech and freedom of expression. And it really depends which side or which way you approach the problem. So if you believe that the government should be more should regulate more, then you're going to be the one that is going to advocate more for regulation. And you're going to want to protect the child, and you're going to want to work in the public interest. And you're really going to believe strongly that regulation is the solution, versus the other approach is, well, that violates freedom of expression and the individual's interest and their autonomy. And while children have the right to both, they have the right to be safe, which is the development of appropriate guidelines for the protection of the child from information and material injurious to his or her well-being. So the child has a right to be protected, but they also have the right to have freedom of expression. And so again, you can see how difficult this is. And even in practicalities, if the government intervenes, how is it going to get down to that level of protecting that suicide and self-harm related content? Because, and this, my colleague, Marc Signor, who I know is on the call today, he and I have talked a lot about the idea that social media really is a broken playground. So at some level, even if it's just ethical or moral, why aren't we regulating social media, even if it doesn't work, and even if it might violate freedom of expression? I mean, people have freedom to play in a broken playground, but we don't let them. And the reason why we don't let them is because there's strict regulations about how the materials should be constructed. And if there was a broken swing with a caution tape around it, nobody would go there. But none of those constraints exist on social media. And to some extent, we've lost common sense or the way we usually approach things. So I echo Dr. Andrea, and that action is needed. We really do need to figure out how to manage this problem. But the problem is not necessarily going to be with regulation, because regulation is problematic. We're behind here in Canada, very much so. Australia is leading the way, and then the UK, and I'm not sure what's happening with our colleagues to the south, but in the US. But in the Canadian context, we had a whole bill, and now the government's changing, and it basically is not going to do anything. It's obsolete now, this bill. But the problem with it is that it didn't even have anything about self-harm and social media content. It just has online content, anything that's going to harm it. And my lobbying colleagues, who I've since discussed this with at length, have told me, well, that comes from the recommendations that are specific, and the legislation is just overriding. But nevertheless, it was going to all be governed by a Digital Safety Commission. And who's going to form the Safety Commission? How is that going to happen? And how is that going to stop Demeter, or how is that going to stop Persephone from falling in love with a goddess of the underworld, if that's where she feels better? And that's the metaphor, because no Digital Safety Commission or amount of legislation is going to really affect that, because the limits of regulation are that it's too broad. It doesn't target that content specifically. There's problems with enforcement. Youth just go to where they can get it, right? We all know that. It may, in fact, remove the access to helpful content and supports that are there because we are removing the concept altogether. And will it actually help poor Persephone and Demeter come back to each other? And what we really need is a multifactorial approach that is in part related to the legislation, but I happen to think it's more about the less about the practical and more about the moral and ethical and societal obligations we have to our children to regulate certain things that are obviously going to be harmful for them. But then we also have to think broadly of how we're actually going to protect them. And that involves family, peers, schools, as was so excellently pointed out in the previous presentation, clinical care. It has to be part of our treatment plan. And I think the lesson that we can learn from Demeter and Triptolemus. So what is this story? So Demeter is the goddess of agriculture, as I've mentioned. And she gets really upset because her daughter, her dear daughter, is basically lost in the underworld. And not only is the daughter lost in the underworld, she also says she doesn't want to come back, and she's in love with the goddess of the underworld, god of the underworld. And so Demeter is very angry, and she doesn't feel that she can help the mortals. So what she does is she finds a disciple who, because she knows the mortals have to get the information somehow. So she teaches Triptolemus how to cultivate crops. And the story is that he goes in his chariot around the world and throws seeds off his chariot so that the mortals can start to understand what happens with agriculture. And I think that what we need to do is that social media literacy really is the modern day Triptolemus. We need to find some way to throw seeds from our chariot and teach the mortals how to cultivate the earth. We need to be teaching our children, the youth of today, how to manage in this new world of social media that is likely not going away. We need to plant the trees and the seeds of change at the same time. And we also need to fight the fires that we're very much fighting. And how it resolves is Demeter and Persephone, they come to a resolution. And the resolution is she spends 6 months of the year outside of the underworld. She spends 6 months of the year with her mother, and she spends 6 months of the year in the underworld. And the theory is that, well, it's 6 months of winter and 6 months of summer and spring. And I think that the social with Triptolemus, throwing seeds around from the chariot, and I think that that balance is really what we're aiming for, and between all of these issues, rather than have them compete against each other. And then finally, we have to listen to the youth themselves, because if we do this without them, we will absolutely get it wrong. They are the experts in this. They know far more than we do. And they also know what is helpful and what is harmful. And so we have to listen to them. And so in summary, protecting youth from self-harm and suicide-related content on social media requires a multifactorial approach to put out the fire. And I think we have a lot to learn from the story of Demeter and Persephone. And I'd like to thank you for your attention today. Anybody who has ideas about how we can get this into the global scale of social media literacy, please don't hesitate to contact me. Thank you.
Thank you very much, Rachel. That's really a brilliant presentation, and I have seen colleagues in the chat really describing how important this topic is nowadays, and the importance of the information that you bring to us. You started by bringing very interesting epidemiological information, and as you said, very similar to what we see at the regional level with regional data, where the increases on self-harm and suicide in females are sharper than what we see in men. We have also been seeing with regional data that the mean age of suicide is becoming younger and younger. So this is a very concerning. You brought again the Werther effect and the importance of contagion. We had those discussions in one of our previous webinars, but you really expanded to very modern and current topics, which is how this influences or permeates social media, who is so present in the lives of everyone today. And I think another very important topic that you also mentioned among many important topics is going beyond the individual, but also emphasizing how the environment, how the determinants that are around young people can be so influential and many times negative, especially in relation to self-harm and suicide, which brings another topic that probably should be another theme for our webinars is on how commercial determinants influence mental health, but also suicide. So thank you again for also emphasizing once more the importance of multi-sectoral work, multifaceted approaches, and the importance of literacy as you brought at the end. So great. Please stay with us because I'm sure there is plenty of questions and comments on the topics that you mentioned. Let me then continue. Y ahora me pasaré al español.
And now I will switch to Spanish. Our next and final presentation is by Dr. Belén Vargas Gallegos. Dr. Vargas Gallegos is the National Manager of the National Suicide Prevention Program of the Department of Mental Health of the Ministry of Health of Chile. She's a doctoral researcher at the Millennium Center for the Improvement of Adolescent and Youth Mental Health. She's dedicated to the design and evaluation of interventions for the promotion and prevention of mental health and school mental health, suicide prevention, and the transfer of knowledge to public policy. Thank you for being here today, Belén. The floor is yours. Thank you, Renato. It's a pleasure for me to be joining today. Hello to everyone who's online, both on Zoom and in the YouTube broadcasting. And thank you to the Mental Health Department for all the help, and also to the University of Toronto. I would like to share some of the work we've been doing in my country. This is the work of over a decade now for suicide prevention in adolescents. And for that, we've tried to advance suicide prevention in educational establishments. This year, I wanted to focus a bit more on implementation strategies to reach to the adolescents in our country. This is the framework of my presentation. First, I will share some national contexts. And for that, I will talk about the National Program for Suicide Prevention in Chile. I will also tell you what this intervention model looks like in educational settings. And then I will talk about the implementation strategies of the model we're working on right now. I will also share some examples of how this looks like. Finally, I will share some key lessons that we've learned so far. Throughout my presentation, you'll see some QR codes. And by scanning those QR codes, you'll be able to access digital resources. They are free for everyone who scans that QR code. So, a little bit of this road we've traveled. Our country started developing suicide prevention strategies early on. Somewhere in 2007 were the first regional strategies. And formally, the Suicide Prevention National Program was set up in 2013. This was a national program, and we're very proud to say that we were one of the first 28 countries to implement this at the global scale. This was specifically addressed to prevent suicide. This model was based on intersectorial work by having the Ministry of Health at the core of all these sectors, and it had the advantage that it could be adapted to each local reality in our countries. There were 6 elements in this program, as you can see here: epidemiological surveillance, healthcare training, crisis helpline systems, intersectorial regional plans, responsible media coverage, And finally, prevention in educational establishments. We are now moving from a national program on suicide prevention to a national strategy on suicide prevention here in Chile, hopefully to reach to all civil society members and other stakeholders. And we look forward to showing this in the future. I apologize for the interruption. Belén, there are comments here. If you could maybe talk a little bit louder, or maybe is this better without headphones?
Parece que está mejor. Sí. Está mejor. Están comentando acá que está mejor también. Y un poquito más despacio para los intérpretes, por favor.
And remember to speak slowly because we have interpretation. Well, in this framework of the national program, we move now to the intervention model. This is what I will present now. This model was developed after doing a thorough research and analysis of available data, also analyzing international experiences. All of this was integrated into our model. And this model has 6 elements and covers interventions that are proven useful to address suicide behaviors in adolescents. This model also highlights that suicide as a phenomenon is not an isolated issue. It does not happen to a single adolescent, but it is actually the result of multiple factors. And so a community-based approach is necessary. This model is also customized to the size of the Chilean Ministry of Health. While it is nourished from other programs, it is adapted to local realities. Our perspective is also whole school. This means that the model does not aim for the creation of a specific program for suicide prevention, but rather what we do is recommend and suggest resources currently available at schools, or suggest other practices so that the everyday life at every school can take place considering all participants. This means students, but also teachers, parents, caregivers, and the community as a whole. So as you can see here, this is a graphic view of our model. It's multi-level. And on the one hand, we have interventions that are addressed to all members of the school community. And this is the green arch here, universal prevention. And for that, we can develop universal prevention strategies, also focus on how to prevent suicide from a more global scale. Simultaneously, our model also has this yellow arch here, which has to do with selective prevention. This means identifying potential adolescents at risks. And for that, we need gatekeepers or community guardians, so to speak. And we also have the blue arch here, an indicated prevention sphere, which has to do with action protocols and post-intervention protocols. This come into place after a suicide has occurred. And this involves offering support for the community that's been impacted and also offer ways to prevent further suicides. All of this needs to happen within the coordination efforts between education and health. And this is the overarching orange arch here. The idea is that this happens from an outside team too.
We also told ourselves that in order to prevent teenager suicide, it was necessary for every institution in our country to adopt this model. So we asked ourselves, how do we get there? How do we get to this universe of 3.5 million children and teenagers in primary and secondary school who are in more than 10,000 educational institutions? We have public, private, and institutions, public institutions, depending on the state and private institution, of course, for private education. For them, we wanted to make an extra step, and we didn't just stop with an intervention model, but rather we wanted to give, and we gave an implementation model through different strategies that could implement this model, to facilitate the implementation of this model, and also to show simultaneously the different levels of education, both at local level, at school by school level, but also at regional management level, and of course at country level. So I will share with you now the different strategies that we were able to implement, and we believe that those are the right paths to be able to own such model at country level. The first strategy to implement is the one we know the most, which is technical leveling and information sharing. So the first thing we did was to elaborate a guide to prevent suicidal behavior in educational institutions. And what we did before was involve with just the health team, but this time we gave material directly to the educational team and personnel. So adapting models to local realities, and the idea was widely shared. And also important to mention that the Ministry of Education in Chile was part of this project, facilitating the adoption and adaptation of the languages and of the terminology to the educational system in Chile. And together with the recommendation guideline, we also developed a permanent offer of educational activities for educational groups and teams. We started right before the pandemics. We were able to implement the first practical workshops, theory and practical workshops, and we pushed the educational groups and teams to participate in workshops during 12 to 16 hours concerning suicide prevention, and also bringing that to practice, highlighting day-by-day practice and activities. Then, beginning in 2021, we started to have a strong collaboration with the Ministry of Education, and we started executing training activities together with them, collaborating with the ministry. So we had a first set of online courses for teachers, supporting groups, schools, but also public servants of the Ministry of Education, so that everyone could reach this strategy. And also, we also developed audio and visual capsules to share around, and how to prevent suicidal behavior in their establishments or schools of first and second level. So one of the strategies that we were able to use was being able to support and facilitate the articulation of the different stakeholders in the suicidal prevention and local level. So one of the ideas was to work on active protocols for educational institutions for students, and that was proposing a standard model that was able to be adopted and adapted to every local situation. So every city has a different protocol, and the idea was to have a common framework and language, so that the team of a school could easily be able to communicate with a health team, where usually languages and terminology is not the same. So we defined universal tools, we adapted it, we got authorization to adapt it to Chile. And this scale and this model consisted and gave a common framework for the educational institution in our country. We were also able to have a common response at regional and local level for specific cases, for example, tentative of suicide for students. We have protocols of activation among and between 24 hours from the the interpreter is sorry to say that the speaker has frozen and we're not Belen got frozen, didn't she?
Sí, está congelada, Renata.
Yes, she's frozen, unfortunately.
Quizá esperamos un
Maybe
poquito.
we'll wait for a bit.
Si se perdió la conexión.
I think we
So no-
lost connection with her.
Belén, tú estás de vuelta.
Maybe she's back. Belen is back.
Estaba congelada creo que por unos 20 segundos.
Perfecto. Voy a apagar mi cámara.
All right, perfect. I will turn my camera down so that the connection will
Sí,
be possibly stronger.
Cualquier cosa. Dame un segundo. Sí, les estaba contando del protocolo de articulación.
I was speaking about the action protocol
y salud.
between
¿Puedo mostrar mi
education
pantalla, Renata?
and health
perfecto.
teams. I'm sharing my screen. Could you confirm
Entonces,
that?
con
Yes.
este protocolo, ¿qué es lo que
Therefore,
hacemos?
with this protocol, what is
Acciones
it that we're doing? We're establishing
apoyo
immediate
educativo,
actions. So
tanto
to
el
help the
Ministerio de
educational
Educación
support, the
como el
Ministry of
Ministerio de
Education,
Salud,
but also the
y
Ministry
también
of Health.
proporciona pautas para un manejo
And it also
comunicacional
gives
que sea
guidelines to
seguro, para informar a la
um,
comunidad y también
inform the
para
community and help the community
prevención.
in prevention, in suicide prevention.
Inmediatas con la escuela
So
afectada,
active and immediate
coordinación
actions
para
with
definir
the
apoyos
concerned
extra, por
school
ejemplo,
and getting possibly
esa
extra
comunidad.
support
Y también
that a
establece
community might need. And also it shows how to establish
esta continuidad
following up
de los apoyos
protocols
pueda ocurrir en el
to continue and giving constant support during time and on a long-term basis.
Y dentro de las estrategias que son más desafiantes,
Within the most challenging strategies, but very efficient one as well, those are the ones that allow us to institutionalize such processes in general, not just in our country. And the strategy, those are the strategies that allow modifications in the system. So betting on and working on long-term changes to adapt this model. This has to do with the importance of giving space and priority to suicide prevention, not just a health topic, but also in the framework of education. So the first highlight that we defined for them was to include suicide prevention as norm obligation for the educational system in Chile. So this is the entity in Chile that regulates and supervises and manages all the educational institutions in Chile. And we were able to include in their norms a very important article for us, which is the need for each school or educational institution, both private and public, need to have guidelines for possible risk cases for suicide and also a management protocol for suicide attempts, and also implementing activities for general suicide prevention. So this was part now, thanks to us, of the norms for the Ministry of Education and Health, and we put at disposal the model that we've been working on, and I presented so far. In 2023, we were also able to consolidate the intersectoral collaboration with the ministries, and this was the same bet that the Ministry of Education in Chile does to give a good follow-up to what had happened during the pandemic years with students and with all the courses online that were established. So this was part of our model. So first acts would be mental health and strengthening all the social-emotional aspects of co-living and gender equality, mental health from a pedagogical point of view, so that the educational communities can be spaces of protection and well-being. So the strategy of mental health in educational communities goes together and was linked with training and in suicidal behavior prevention, which means that now suicide prevention is not just a responsibility of the health ministry, but also part of the Ministry of Education protocol. Something else that I want to share with you today is, without a doubt, the most challenging sphere, which is how to incorporate the participation of teenagers themselves while creating policies and in the decision-making process. So in Chile, in order to create that policy for suicide prevention that I was speaking on before, we worked on different mechanisms of participation to showcast this to the different parts of the population, to show also where our country wants to walk towards, and which are the priorities for teenagers to incorporate in this new strategy. So at the beginning, we were able to define as participation mechanisms civil dialogue, where we had organizations connected to teenagers and children. But then we created a new mechanism where teenagers and children could directly participate. We were able to do that together with the Ministry of Education, with the Civil Society Council, and the Ministry of Education and the students of the Ministry of Education everywhere in the country. And these were the important topics that were prioritized by these occasions of youth participation. Those are topics that are at the core of what we want to do to be able to move forward in suicide prevention for young people. So first topic that they wanted to prioritize was the creation of safe spaces, not just face-to-face, but also considering online platforms. We saw the presentation done today, and we knew and heard the importance of social media. So we put in this first topic healthy communication as a basic step for higher education, so safe space and safe communication for the youth, and also more regulation for the access of little tools. So for teenagers at risk, what we wanted to do was to create youth participation that is also linked to local realities and be able to focus on special groups, specifically people who don't feel so part of a system or belonging to a system. We also spoke about youth participation in regulations and decision-making processes, but also giving space to community prevention, and last but not least, innovation for intervention. So being sensitive to different contexts, but also having innovations in terms of interactions and technology that could be a huge ally for this development. As part of the key learnings that we got out of this process, we want to tell you that it is possible to work intersectorially to be able, and we also want to say that it was possible to find common goals, and not just in the Ministry of Health. It is impossible to just speak and face all different challenges just in the Ministry of Health. We need that intersectorial articulation and work. So it is important to translate this knowledge and these experiences and connect logic so that we're able to create common actions that make sense for all sectors. And in this point as well, the main learning for this presentation is to insist to be able to see the different results in the model that we propose. We need implementation models that can be tangible and concrete so that they can push us forward, that can implement these models in an effective way. It's not just about creating a course, it's not just about creating a line to implement. We need to mobilize everyone at different parts of the system. We also want to speak about youth participation. It's important to create authentic mechanism for participation and decision-making processes. Those will allow us to overcome approaches such based not on youth participation. And we want that participation not to be just symbolic. It has to translate into change, real change in the next strategies that we'll be able to implement in our system, in our country. It's important to highlight the help that we got out of teenagers and children participating in our activities, and also to get their feedback. With that, I'd like to thank you, everyone, and also highlight the possibility of sharing strategies with you, what we used, but also what can help you out, generate new ideas so that your own countries can implement development and move forward in suicide prevention, so that all the contexts and situations can turn into reality and help teenagers. So thank you very much.
Muchísimas gracias a ti, Belén. Excelente
Thank you,
presentación.
Belén. Excellent
What you
presentation.
just mentioned is the reality. There are colleagues here in the chat who work in ministries of education of countries in the region who are really interested to learn more about the experiences of Chile. I'm already answering some of the questions people asked. Are we recording? Yes, we are recording. It's going to be at the recording will be available at the PAHO webpage, but also at the PAHO channel at YouTube. So you can share, colleagues who are here participating can share among their colleagues and people who are interested to hear the experiences of Chile. I think you gave us really fantastic lessons, Belén, on how to work at national scale, on una escala nacional, and you went step by step. No implementation of an action plan. Development of guidelines, guidance for schools, all the material that Chile developed for training, capacity building. You shared with us also how the sessions were organized, and a lot of material that you also made available during your presentation. Some of the colleagues were having difficulties to access the material with the QR code, but I believe they are all available if colleagues go to the webpage of the Ministry of Health and Ministry of Education. I imagine that all that material can be available there. So thanks for sharing. It's really going to be very useful for other countries who want to advance in those processes. And there are many countries doing that because fortunately, suicide prevention is becoming more and more important in the public health agenda of the countries of our region. You also shared with us many protocols, not only for the health sector, but also for the educational sector. And last but not least, the involvement of young people in all those processes. You showed us how to operationalize that involvement. Many experiences we hear on the importance of involving young people in those processes, but you really showed us how to operationalize, how to make it happen. So thank you again. Muchísimas gracias por tu presentación.
Thank you so much for your presentation. We have a little time left. Panelists, please stay online. Unfortunately, we cannot get to all the questions we received, but I think we can tackle a few. And Belén, if you allow me, there's a question that's very much connected to your presentation. What do you do to ensure the protocols are implemented? The protocols you shared with us in schools, I mean. What do these surveillance or monitoring mechanisms look like, or assessment mechanisms? What do you do on your end if some of the schools fail to implement them? Maybe you can tell us a little bit of that? Sure. What we do in Chile, well, first of all, the educational system here is huge and covers plenty of schools across the nation. On the one hand, we're supported by this nation, the Superintendency of Education in Chile. And as I said, protocols are part of the requirements. schools are obliged to comply with. And so there are auditing mechanisms, and once schools are audited, they make sure that the school has these coordination mechanisms in place. And then separately, we do technical support or accompaniment. And our goal here is that rather than thinking about a protocol for one school or one center, we want regional or community-based protocols. So it is in the establishment of those protocols, which is done based off of the standard protocol, each territory then creates their own protocol, involving all relevant stakeholders at the educational level, and then formalize this. Of course, this is a lengthy process that requires negotiation. It requires identifying key stakeholders, but we've had plenty of positive experiences across the country involving the application and sustainability of several protocols. And this is a way to support teenagers who require this.
Muchísimas gracias.
Excellent. Thank you
Belén.
so much, Belén.
Rachel, there is a question here coming from many sides. It's a very important question. So we as health professionals, what are the recommendations that we should be giving to parents in relation to social media and many of the risks that you describe? How we guide parents who are worried, and many are worried these days. What do we advise us to advise them?
Very, very, very important, very good question. One I ask myself as a parent of every day, and I don't think we have it perfectly figured out yet. However, on balance, I would say in adolescence, you want to respect the teen's autonomy. You want to give them their space. And so, however, I think more is more is needed than that typical approach. So I personally think, certainly starting from a very young age, needing to be talking about what's out there, what's online, what the risks are, what the harms are. You may want to go to the extent of implementing some of the measures that can be used. I find them very difficult and hard to navigate, meaning like the regulations or the rules or the parent controls and all that. I find it personally very difficult. I do them, but the best thing you have is a conversation with your child and the relationship, and that regardless of what you're doing or seeing online, you're able to hear about it. I don't love the idea of parents checking their kids' phones without them knowing. That as a child and adolescent psychiatrist can create a lot of problems. But if you're worried that your child is in danger in any way, then that's a different story, obviously. But communication, being in touch, talking about it more, as much as you possibly can, and being aware, being involved in what they're online. I think you were more talking, the question was more about the quality, the nature of the content as opposed to like screen time, because that's a different topic.
Yeah, no, thank you so much, Rachel. You remind me of many years ago training in child adolescent mental health, where we really worked with parents to maintain that bridge, the bridge of communication between parents and kids, because that's the way that information flows, and we are attentive on how we can support our kids. And they are going to be also coming to us expressing their worries and their challenges without fear of punishment. And this is so important to maintain that bridge open of communication. Thank you so much, Rachel. Andrea, there is a question here that it connects to your presentation. What about kids who are out of the school system? What is the experience of you guys in UNICEF? You explained to us a lot of training, capacity building focused on kids who are at school. How to also implement HAT, those activities, being able also to reach kids who are not at school, because unfortunately they exist in our countries.
Thank you, Renato. I saw that question and replied to the person in the Q&A,
Oh, great.
but I can repeat quickly for everyone who are listening. I think what is important, it was also mentioned by Dr. Rachel, Dr. Belen, is to be able to create that intersectoriality and communicate and bring every important key stakeholder on the same table and understand the role and accountabilities that everyone has. It's not only the education sector, it's the health sector, it's the protection sector, and any other professional that is working with adolescents. So in our experience, the schools for such a type of interventions that are focusing on prevention, promotion are ideal. However, for those kids who are not in the school system, of course, it's more challenging to reach them. And also through the health sector, it's challenging because we know that during adolescence is a time period that adolescents don't reach so much health services like in other life periods. However, it is important to be able to find spaces that would integrate this kind of promotion, prevention interventions. So in Venezuela, we had the Ministry of Health participating in the first cohort of training, and they identified as an ideal setting the integral health, adolescent health consultations, which are part of the community health services, where they would train general practitioners or pediatricians to be able to use the knowledge that is provided and the skills that is provided through the HAT in order to identify teens that are at risk and use the skills to promote and prevent suicide, but mainly promote mental health. Other spaces in Ecuador is community centers. So, for example, in Manta, in the Manta city, there is a big and very beautiful modern space facilitated by the municipality, and that space is ideal for extracurricular activities, and it's accessible by all kids and adolescents in the community for different types of activities. It's like a safe space that offers all types of services. And that's another place where it's available and ideal to implement HAT. So I think it depends on the context and what is available at the community level and how you approach, a strategy that will allow children and adolescents that are not at school to access this kind of services. And of course, community and public communication about suicide prevention and mental health promotion through different means, digital, social media, etc.
Okay, I think we are reaching the end of our time. Gracias a nuestros participantes por compartir sus preguntas.
Thank you to all participants for sharing the questions. We are now reaching the end of this webinar. I would like to thank our presenters, Drs. Prideaux, Mitchell, and Vargas Gallego, for taking the time to share their experiences on this very important topic. And of course, I would like to thank the University of Toronto for their partnership and collaboration in this webinar series on suicide prevention. We hope to see you all very soon on the next one, and we will share more information about it soon enough. PAHO is committed to supporting countries in the region to advance suicide prevention through effective evidence-based strategies. Working together, we can prevent suicide. Remember also that if you or someone you know is in crisis, please seek help from a medical professional or contact your local helpline. Thank you once again and have a good rest of the day. Thank you. Goodbye.